See, this is what Dr. Sanders was talking about. See, back in Kentucky, where I'm living now, we got a problem called biscuit poisoning. Y'all call it just fat, but we got a real name for it, biscuit poisoning. Because in Kentucky, we eat mud if you fry it. But that's what happens if you get the turn on the microphone. Anyway, I'm in trouble for saying that about him. Our next speaker is Dr. Eric Flenaugh. Dr. Flenaugh is an associate professor in the Department of Medicine at Morehouse School of Medicine in Atlanta, Georgia. But more importantly, he's also the chief and director of the Pulmonary and Critical Care and Interventional Pulmonary Medicine at Grady Hospital. And he's the director of the Georgia Cancer Center Advanced Diagnostic and Interventional Pulmonary Services. And he's the director of the Lung Nodule Clinic at Grady Hospital. He's going to address today what's new in lung cancer screening, care, and treatment options. Dr. Flenaugh.
Thank you. Yeah, I'm not the perfect doctor. Don't answer that. Thank you for coming out. I like doing these talks, but I'm going to do something different. I'm going to come off the stage. They love it when I do this because I move around. And the reason I do this, if people don't understand, back in July of last year, my uncle was diagnosed with lung cancer, and we lost him in August. Okay. In October of 2019, my dad was diagnosed with lung cancer. And this past May, he came down for my twin daughter's graduation out of high school. But as we went through this, I've been in the same situation that you were, sir, with your mom, right? And it makes a difference. It makes a difference when people talk to you. Your story was so powerful because it makes a difference when people talk to you, when you understand and you know what the next steps are. And so my purpose through all of this talk is to get you some understanding about this because there are disparities with lung cancer. And a lot of these disparities come from people not having that literacy, that health literacy. And without having that health literacy, we can't change some of these disparities. And when I talk about disparities, I'm just going to do a little bit of recap. This is part 2 of what I did a year ago, but there's some important parts I wanted to recap on. Is that these disparities, these differences in healthcare, differences in lung cancer, come from a difference between the imbalances in health and healthcare. And the health for us are the environment and biology that we either have or we're exposed to and how that impacts your health. And then healthcare are the healthcare systems and the factors that influence getting through that process of getting to where you get to cure and that you're still here. And then afterwards in the survival part. So I want to run through that a little bit. And let's go a little brief recap on this environmental and biology that impacts our health. And I think we all are aware that the number one cause, I don't even have to show you this slide, right? The number one cause of lung cancer, smoking. About 95% of it is smoking, okay? Number 2 is radon, okay? But radon is number 1 for people who have never smoked, right? And that's extremely important. And so if you know people like that, and it doesn't just have to be lung cancer, it could be breast cancer, it could be colon cancer, but radon is a radioactive product. It comes out of the soil, comes out of where people may have had factories before or power plants. It doesn't have a taste, doesn't have a smell, doesn't have a color, comes up into your house, and it distorts your DNA, and then cancer develops. So if you have the opportunity to get back and speak with our firemen back here, they have some education about this and how to keep your house safe and how to get things tested. I think it's extremely important. And then there are other factors, asbestos, we hear about chemical factors, just having lungs. You don't have to have smoked or had all these exposures to get lung cancer. You may just have lungs, and that puts you at risk. Okay. So, sorry, I'll keep moving. Okay, so an important thing, when we talk about biology, there are things, I hear this so much from my patients, right? My body's different. Our bodies are different. You guys say the same, ours different. But there's differences between races, exposures, ethnicities, etc. But in African Americans, you heard it when we started a little bit earlier, we have a higher risk of developing lung cancer than other races, despite equal levels of smoking, right? And this is what I want to show you. If we look here on your left-hand side, lung cancer incidence rates, and we have African Americans, we have whites, and we have Native Americans. And those rates, those are per 100,000 people. We don't worry about it. Just look at the numbers: 74, 64, and 49. So there's about a 10-point difference between whites and African Americans. And then you get almost 30-point difference in terms of the rate of developing lung cancer between the races of Native Americans and Alaskans. Now, on the right-hand side, you have this amount of smoking, the prevalence of smoking. African Americans, the yellow is men, the orange is women. So 25 versus white men, 23 versus 42 for Native Americans. So significant, so between African Americans, whites, it's about the same. And for women, it's 18 and 20. That's about the same, right? So come back over here and look. 10-point difference despite being same. So this tells you that the biology is different. There's something about African Americans that makes them more susceptible to the bad effects of tobacco smoke. And if you don't believe those numbers, look at the Native Americans, right? Because look at the men, 42, they're almost double, right? But still, their rate of developing lung cancer is almost half. So this is telling you something, that biology does matter. And if we don't know about this, but we continue to do some of these things, then we're putting ourselves at risk. And so this is why it's important to learn this. And we do know that there are some things that we kind of don't pay attention to, we downplay. So I have this as the undertone. What I've learned over this time, and I probably diagnosed close to about 160 or 180 new lung cancers in 95% population, the population we diagnose are African Americans. So we see this. So what I've learned over the years is, I don't just have to ask, how much do you smoke and how long have you smoked? What else do I have to ask? What do you smoke? So let's talk about this a little bit, because I don't think people really understand this, and this is important, right? This is really important. So it's not the nicotine that causes the cancer. Got it? It's the 6,000 other chemicals that come from the burning products and the preservatives that they put in it that cause the cancer. Okay? The nicotine keeps you addicted and going back even though you know it's bad. So this is not to downplay or put a lot of stigma on people that smoke. This is to say that there is something, this is an addiction that we have to focus on. The problem is it's legal. The problem is that there's money linked to it. If nicotine were a new drug coming out today, the FDA would have a problem with it, right? Because there's money behind it, because there's politics behind it, it gets a pass. But it is equally as addictive as cocaine and heroin. Okay, it's so addictive like that, and they know it, that the FDA regulates it. So we know that each cigarette has about 8 to 10 milligrams of nicotine in it. So what that means is we can calculate off of all these other things that people smoke, the equivalent of cigarettes that's linked to it. So these small cigars, and you'll see, the Black and Milds, the Swisher Sweets, those are things, right? Each one of those has about 100 milligrams. That comes out to be about 12.5 cigarettes, right? Because I've had young people that come in with, 34-year-old. He came with stage 4 lung cancer. He said, "Doc, I only smoke 4 a day." I said, "4 of what?" 4 Black and Milds. I said, "You're a 2-pack-a-day smoker." Right? There's a reality to this. And the large cigars, oh yeah, we just do it our little game. Yeah, that's about 25 cigarettes. That's over a pack in one sitting. I only smoke 1 a day, as people tell me. Yeah, you're smoking over 2 packs a day. Okay? The new things that have come out, the electronic cigarettes, these pods and stuff like that. So how many cigarettes in the pack? 20? Okay, y'all should know that. Gotcha. I do the same thing. I do the same thing for some high schoolers. Every year we go out there and I ask them that, and I say, and I find out some of them tell me. And their friends look at them. How do you know that? Okay, got it. So some of these pods you see, and you guys have seen it, right? I don't have to tell you about it. They take a puff, you got a big plume of smoke coming out the car window, right? Okay. One of the jewel pods is about 41 cigarettes worth of nicotine, right? The puff bar jumps it up to almost 50. The thing I don't like about that one is we get back to that menthol and making it easier and smoother for people to continue on with that. And this one, I think they just need to take off the market because I've seen people go through 2 or 3 of these a day. There's about 90 cigarettes in each one. But what happens when that gets too expensive? What are they gonna do? Go right on back to cigarettes. Okay? Yeah, anybody go to hookah bars? Okay, don't go. Don't raise your hand. Got you. So, you know, you go around, they pull out the pot and they have the little thing and they pass it around. So I tell everybody this is when one of my friends comes up with a cup of something and they say, here, you need to taste this. And I look at that straw a little bit crazy, right? I don't know where your mouth's been, right? You got people sitting in this little bar area and then they're smoking and passing around. They get an hour session worth and it's about 200 puffs per session per person, right? That turns out to be about 100 cigarettes per session, about 5 packs of it. Now, are they going to a hookah bar every day? No, but what is it doing? It's telling you that you're getting something very addictive in a socially acceptable environment that's fun. And so, okay, it's not that bad. And then that comes on, that little high comes on. You say, okay, yeah, I'll go smoking with it. And then that's where it starts. And they know this. And then there's this. So it's been a while, right? So it's legalization has now come along that we now know, because in the beginning people say, well, marijuana doesn't cause cancer. Well, we didn't have enough study, but when it started getting legalized, we started to be able to, get some studies to tell how much people use and when they use and whatever else. And now we know that if you are a heavy user, keep that word heavy in your mind for a second. You're a heavy user, you have a 2-fold risk of developing lung cancer in your life. You wanna know what a heavy user is? 50 times in a lifetime. No, I didn't say week, because y'all know some people. You know some people, right, in a lifetime. Oh yeah. You know some people roll it real fat, huh? Yeah. Mm-hmm. Yeah. I don't know how much is in there, but it's a lot. Got you. So this is the recap we need to know, and that's the part. But now I want to move on to part 2. And part 2 is now the healthcare system. How do we factor in, and how do you use the healthcare system to your advantage? And the only way you can do that is by the knowledge of what we should be doing and how to make it work for you. And that is through early detection, finding that cancer early. Any cancer, you find it early, you have a better chance of surviving. And how to find it early while working through the system, it's working. So the first thing you have to remember is the screening, okay? Screening. Our goal for screening is to help find it early. And there are criteria for screening. If you don't know these, but you know someone that smokes or it's you that whatever else, pay attention to these, take a picture if you want, because this should qualify you to get screened so you have a chance to find it early. If you are between the ages of 50 to 80, if you either currently smoke or you smoked any time in the past 15 years, and you have at least a 20-pack year smoking history. And when I say 20-pack year, what that means is if you smoke a pack a day for 20 years, that's 20-pack years. You smoke half a pack a day for 40 years, that's 20-pack years. Right? If you have that history there, you need to talk to your primary care, like you heard, about the opportunities for getting screened and detecting it early, because screening actually does help you save a life. So some of the studies, so the people used to get x-rays before, and what we found that the screening involves a CT scan. It's once a year. And it's better than a chest x-ray. You say, oh, I had a chest x-ray, didn't see anything. No, that's not as good. Get a CAT scan, it's once a year, it's a low dose of radiation. You sit there, you walk in there, and 20 minutes later, you're walking out of there, and then your doctor will call you with the reports later. But if you do that, it's a 20% lower chance of dying of lung cancer than if you get an x-ray alone. And if you we found that if across all the studies nationwide, for people that get the yearly screening, this CAT scan once a year, they have a 25% less chance of dying of lung cancer. Okay? That's across the entire nation, right? The population. okay? Because the goal is to find that little spot in this CAT scan where here are your lungs and the edge of the lung, and you find that little spot. The reason that's important because on the edge of your lung, you have a lot of nerve fibers. Anybody know someone's bruised a rib or broken or bruised a lung? It hurts, right? It's very painful because a lot of nerves there. Anybody that has something in their throat, you have a tickle in your airways? Yeah, you cough a lot. But in the middle of your lung, there's no nerve fibers. So that little cancer that develops in that area goes undetected till it causes a problem. And by the time you have the problem of pain or you're coughing up blood or you're losing weight, it's usually spread already pretty bad. And so who gets left behind with this screening? So African Americans, here's the thing about it. Remember I said 25%? Okay, but when you break the populations down, the survival benefit is more for African Americans to get screened. It goes up to 39%, almost 40% improved chance, right? But we're less likely to get screened. How many before coming here knew that there's opportunity to screen for lung cancer? That's what the studies show. Less than 50% of people even know that there's an opportunity to get screened. But right now, you have that knowledge with you, okay? And screening in minority communities, if we screen in communities, in our communities, then we can close that disparity, that health gap, okay? Because what I want to show, the screening helps you find it early. The top line is early diagnosis. The light blue is African Americans. The dark blue are whites. And if you can get what's happening currently because the screen is not, is there's a gap that the early diagnosis is more likely to happen in whites than it is in African Americans, right? Part of it needs to be, the part of that we can make the changes that we can decrease that is just by going in and asking for it. Speaking with your primary care, for those people that you know that you go to that appointment with them, make sure they're saying the right thing. Women talk going to the hospital with their husbands, because I've seen it, right? And speaking up and say, you need to get screened. That education makes a difference because then the survival curves make a difference. So say you go through, you get screened, they find something, that abnormal screening. What does that mean and what does that account for? We talk about nodules, okay? And you heard it earlier. You heard Ms. Morales talk about nodules. They saw a spot. They saw a nodule. That's all it is. It's a spot that we see on that CAT scan, and we need to figure out what they are. 95% of them, so this is, are nothing. They're benign, right? 95% of them are benign. But what happens is people are afraid of finding that spot and what it is, and so they kind of pull themselves back. No, that majority of them are nothing, but we do keep track of them. They might be benign. These little spots on the CAT scan that you see might be an infection, might be scar tissue, especially if you worked, in industry, because everything goes in and out of the lungs, okay? But we're looking to see if is it solid, is it part solid, does it have any characteristics? Because we approach each one of those spots in a different way. And if you do see a spot, your question is, okay, doc, based on what you see, what is next, right? No, don't play it off. And so, sometimes I see people say, yeah, I see the spot, but I saw a CAT scan you had 8 years ago, and it looks the same, hadn't done anything. Probably don't need to do anything, right? Then I said, oh, you didn't have this here last year, but now it's there, and it looks pretty large. We need to do something. So that's what the importance of that is. The reason that I really focus on this is because we actually looked at this. We had a study we did, and it got published a couple of years ago. We found that asking these questions, when you give people the literacy, the education of what to go in and ask for, whatever, they're 3 times more likely to have a better outcome if you understand what's going on and what we're going through. Okay? And so these programs, when you go into a screening program, you need to make sure that everything that they're explaining to you is in language you understand. You heard about the assembly line approach. That doesn't work, right? Because what happens is when we get into this assembly line approach and we're just kind of pushing things through, then things get lost in translation, or they may not even get translated. They may not even get spread. But our understanding on our side is they didn't ask me any questions. They must understand everything. And then it gets confusing. And then also find a program that has patient navigators. But the next thing after we see a spot, we got to figure out if it's cancer or not, because now we're on a time clock, right? Because it does no good to screen and find something and then sit back and watch the natural progression where it grows and spreads, right? And so we're all on this time clock from there, okay? There is something you'll hear about, the patient navigators, okay? So these are the people that get you through the system, right? So we find something, we say, okay, we need to get this scan, we need to get this follow-up test, we need to get this, and we need to get you back here. That's what the navigators help you do. And we found that especially in low-income environments or people that may even be homeless. These navigators, if you have a navigator working with someone who may not understand all these things or may not be able to have a ride every time they need to get to an appointment, right? Or may not be able to afford all of the tests and the medications, you have somebody working with them, you're 4 times more likely to get through this process in a timely fashion that helps save your life. And so programs with navigators, educators, interpreters, their success rates go up. That's how we target it at our hospital. I think that's how UAB is doing it. We found that these are the most successful processes, so ask for it. Feel free to ask it. Do I have a navigator that can work with me? I can't get to this appointment. Can you help me get there? Okay. And then once you get that navigator, they're gonna try to get you to the biopsy, okay? And all the biopsy means, because I get this all the time. I do the biopsies. They ask, are you cutting on me? No, I'm not cutting on you. I'm not a surgeon. My wife doesn't even give me a knife to cook with, right? But I will get a biopsy, okay? You're getting a small piece to look underneath the microscope, not a major thing. And I can tell you, sometimes there's some of us that are a little bit afraid of, knives and stuff like that. But the biopsy can be either where you're under a CT scan and they kind of follow a needle into it, or that we have a scope and we can go with a little camera scope into the lung and get these little nodules sampled so we can look at it underneath the microscope. And this is not just done by one person decides. Every time I get somebody with an abnormal scan, we're sitting with a surgeon, we're sitting with a interventional radiologist, myself, and we're just trying to figure out what's going to be the most safest, least invasive way to get a biopsy, and it's important. Okay? So what happens if you get a cancer diagnosis? Okay, the thing that you want to, everybody talks, we hear this, staging, what stage is it? 1, 2, 3, 4, what's the stage? All we're asking with staging, all the staging is telling us is how big it is and how far it spread, right? And it's really important. You want to get through that staging part really fast because if you wait, it will spread, okay? But we do know that when you get when you catch it early and you get the stage early, that the survival rate is about 65% over 5 years, versus if you wait and you catch it late, it's about 9% over 5 years. So, and the problem is more minorities are often diagnosed at late stages because we don't know this process. We don't get through this process. But we do know if you can get through that process, get diagnosed early, get staged early, get treatment early, that they all improve, right? The outcomes improve, and it narrows that gap. Get a PET scan is the next thing. It's the easiest. So look, we doctors are not good at naming things, right? So we have CAT scans, we have PET scans, we do whatever else. All the PET scan does is they give a little dye that helps us figure out exactly where the cancer is spread. You can see the abnormal dot there, and then the PET scan shows that there's some activity in there and it lights up, right? And what we want to do is see one spot light up like that. We don't want to see multiple spots show where it's already spread from there. Again, non-invasive. The thing is, PET scans are dependent upon your insurance status. Yep, that's why it's important to vote, okay? And where somebody lives. That's right. And in rural areas and Medicaid patients, they often have to wait longer. But if they see a spot, you need to find a way, work with that navigator to get you to that staging. And do not let it delay. Don't say, well, I didn't get the appointment 3 months from now, because that's just going to give it more time to spread, right? Because we want to get you to treatment. Ideal treatment for most lung cancers, if it's early stage, cut it out, get it out of the body, right? And if not, then there's some chemotherapy, there's radiation, but now there's new targeted therapies. And I'll tell you about those in just a minute. Oh, let me go back here. So, the best way is surgery. So, black men, black women, white men, white women. Who's more likely not to have the surgery? Come on, y'all, I'm standing right here. Somebody has this. We've got to work to get these people where they need to be. I know men, I know we don't stand in the corner right now because they just called us out, right? But we really do need to, this delay. There's a fear of surgery. I get it. My dad went through the surgery. Don't want to be cut on, don't want to do anything. If you cut on it, it'll spread. That's not true. What happens sometimes is if you have our scans aren't perfect, they're only pictures. The eyes, it's what they see, and they'll tell you even the small little changes that the scan might not pick up, whether or not it's there. And so the myth was, well, they went in, they did the surgery, saw it spread, the surgery caused it to spread. No, it wasn't. It wasn't. But getting there and being able to get through the surgery, and even though they have to take a little bit more, they get it. Right? They get it out because it does improve survival, right? So now newer treatments, biomarker testing, and you hear these genes, testing for genes and whatever else. Here's what we're doing with this, and I encourage you on your table. Amgen has been nice enough to leave you these little cards that'll talk about this, and if you ever know anybody that is, yes, those ones. I got one here. You ever know anybody that is diagnosed with lung cancer, you open up and say, do they have any of these biomarkers? So what are we doing with biomarker testing? We're looking for cancer's weaknesses, right? And when I talk about weaknesses, there are new therapies that work to attack these weaknesses. And so when you get this genetic change in this cancer, it helps the cancer grow and thrive, make its own blood supply, and then helps it spread. These are what these gene changes do. So newer treatments say, okay, what happens if we can cut off and stop it from being able to grow? What if we can stop it from growing its own blood supply and its own food chain, right? And stop it from spreading. And some of these treatments either get your immune system to work better, or they target some of these and it helps. And a lot of the side effects from these treatments are a lot less, right? It may be a pill, it may be a shot, it may be an infusion, but the side effects are a lot less in there. And the survival is significantly better because what we have now, as of last year, there's about 39 new targeted therapies specifically for the cancer that the patient might have. It's not a one-size-fits-all with chemo because, one size doesn't fit all the time. But this one's geared to what that person has. And if they have that, and we can target that, we can focus in and get the better survival. The problem is African Americans are less likely to get the testing to find out that they're 28 versus 40%. Right? That's a huge difference. That's 12% difference of not even being tested to know what's available. Okay. So that's the healthcare system. How am I on time? Because I didn't see the little, am I over? Oh, thank you. Tell him again.
He over his time, but he started late,
Yeah,
so it don't matter.
what she said. All right, I'm gonna get done here because okay. So that's what the healthcare system can do. What can we do, right? What can we do after the diagnosis to improve the chances of survival? One thing, quit the smoking, right? We know that if you are diagnosed with lung cancer, you're getting treatment, right? That if you stop smoking, and we help somebody stop smoking, there's a 20% chance, 26% chance of surviving through it. And if it's early stage, it goes up by 10 points, okay? So the reason is the tobacco smoke makes some of the medications not work as well, okay? And do not quit smoking by saying, I'm going to vaping. I already told you about that, but it doesn't help. In fact, people continue to use tobacco products just by thinking that the vaping is going to work. We've seen that. It's a very, and if you try to quit using vaping, your chances of developing cancer go up even higher because the same chemicals in there are higher concentration, making smoke come out, and it's the same cancer-causing things that are in cigarettes. So it doesn't help, okay? And then recognize, right? Because there is a stigma with smoking, and we try to people will put a self-blame on themselves, right? They say, I caused this myself. The problem about that is then you're less likely to be engaged, right? And then you sort of pull back, and then depression comes. And then you know what happens? The tobacco companies have caught on to that, and they advertise specifically towards African Americans. And you can go through time, all through time, they have focused on this. For every advertisement that had one Caucasian person, that you had 10 that had African Americans in it. And you remember the Jet magazine, you just flip them over? Yep. Well, now they've started to have whole marketing efforts towards vaping to keep them going. And look who they're targeting again. Yeah. So, reasons to be helpful. Over the past 20 years, we have seen that the survival rates have gone up, okay? And some of these targeted therapies have been helpful in terms of the treatment. But the other thing is the healthcare system makes a difference. By expanding screening, by biomarker testing, having navigators in the healthcare system, and then building the trust and communication with your doctors. And if your doctor is not communicating with you, myself included, find another doctor. If you can't find one here, come to Grady. Got to. Okay? So with that, I'll just go ahead and close it out. These guidelines, they improve outcomes. Cancer centers around are adopting these, using navigators to help you guys get through the system anywhere. Take advantage of them, ask for them. Thank you. Thank you.